athletes could face and how to manage them properly from a physical therapy perspective and a coaching perspective. A few housekeeping items to note before we get started. This webinar is being recorded. A link to the recording will be sent to all registered participants within a few days, so be on the lookout for that in your inbox. Throughout the webinar, feel free to use the Q&A feature to submit your questions. By doing so, all you have to do is click on the 9 dots on the bottom right-hand corner. That will take you to the Q&A section. We'll have time at the end of every segment to go over questions. Without further ado, I would like to introduce our two presenters for the evening. First, we have Denise Smith. Denise Smith holds a master's degree in physical therapy from Marquette University and founded Smith Physical Therapy and Running Academy in 2015. She also travels nationwide with the Pose Method education team, delivering lectures on injury prevention and treatment and leading certification courses on running technique. As a certified running technique specialist, Denise brings extensive experience in working with runners from an injury prevention and rehabilitation perspective. Her primary focus is on runners and triathletes, aiming to enhance efficiency, reduce injury risk, or recover from running-related injuries. Using tools such as video analysis, technique drills, strengthening exercises, and education, she helps athletes across various sports improve their running skills. Wave, Denise. We also have Jennifer Harrison. With over 25 years of experience in endurance sports, Jennifer of JHC Coaching is a highly respected triathlon coach known for guiding athletes of all levels to peak performance. As a triathlete herself, Jen blends firsthand race knowledge with cutting-edge training methodologies. Jen has coached numerous national champions, world champion podium finishers, Boston qualifiers, and Olympic bronze medalists, as well as Ironman, Ultraman, and ultra running finishers. She emphasizes individualized programming, mental toughness, injury prevention, and community with her coaching. Committed to lifelong learning, Jen regularly contributes to coaching seminars and endurance sports educational opportunities as often as she can. All right, I'm going to hand the floor over to these two beautiful women.
Thank you.
Well, thanks for the introduction, Megan. Jen, thanks so much for doing this with us here. So it's always an honor to be alongside you, and I love sharing and picking your brain on stuff. So thank you.
You're welcome. I'm glad to be here. And I think it's a nice blend tonight. Hopefully everybody can walk away with some tips and tricks and how to manage some of the injuries that you have or stay injury free. And I think it's a nice blend of Denise, who has the practical, experience and the education to talk about the injuries. And then I'm going to take the injuries into what should you be doing and how do we manage them when we're training. You have an Ironman and you've got a hip problem, or you have IT band syndrome or something like that. So we're hoping that you guys can walk away with some real life, tips and tricks. We do want this to be super interactive, so please ask as many questions, and they can be specific to what you have going on. We will keep this to 1 hour, and if we go over, we will do a part 2. So don't worry if we can't get to the specific injuries that we have listed tonight. We'll do a part 2 if we need to.
And you guys can, if we don't get to something that you want to talk about, you can always send us an email. Megan had sent you an email with the login information. You can reply to that with other questions you have, and Jen and I will do a part 2, or we may even do like a question and answer session depending on how many questions we get. So, like Jen said, super informal, just post your question and we'll get to as many of them as we can. Okay, so what we did was we primarily focused on injuries in the lower extremities and some major ones that Jen and I tend to hear the most of. So there might be little ones that aren't presented today, but again, if we do a part 2 or there's something else you need to know more about, just let us know. But this was my kind of joke to Jen about the journey that a lot of you guys as athletes go to. You start noticing something's wrong, you're not sure what to do, you use Dr. Google, you maybe modify some training plans, or you just power through your training plan. You might try like new shoes or taping. And our goal with this is to help you ahead of time to be able to advocate for yourself when you are in front of some healthcare providers like a doctor, but also to understand that there are some things you can still be doing so you're not panicked that you're losing time, or that you're not hitting all the goals that your coach, like Jen, had set for you, but that there are things you can keep doing to keep moving forward without feeling defeated and feeling like there's a big interruption in your training. So I'm going to preface this with, we want everyone to know that this presentation does not take the place of medical advice from any medical provider that you trust. So this is just some clinical pearls that I have learned over time, coaching pearls that Jen has learned over time. So this doesn't take the place of medical advice, but just patterns that we tend to see happen, and our recommendations. So take that for a grain of salt. And the other thing I'm gonna preface this with is I'm gonna sound like a broken record, that a lot of these problems come from weakness and poor technique. So you're going to hear me talk a lot about that over and over and over again, about the role of strength training. And I can't talk enough about strength training. So I do want to ask Jen a question before I get started. Jen, so let's say you program someone and you ask them to run either for time or distance. If they were to say, listen, I really am struggling to get some strength training in, would your advice to them ever be, let's just shave 20 minutes off your run to give you a 20-minute window to strength train?
100% yes. And everyone that's watching and listening to this knows exactly. And there's a couple people that do strength without any kind of disruption, but for the most part, strength is the first thing to go because it's time consuming. You have to think about it. Triathletes or runners don't feel like they get the cardio workout from it. And so it's the first thing to go. And I know everybody knows that, but I'm here to tell you it is the number one most important thing that you can do. And when we say strength, we also mean functionality, mobility, and stuff like that. So things to keep your body moving, body care, keep the joints and the tendons and everything moving. And I think from my experience, I know Denise would probably agree, when we see athletes either acutely getting hurt, accidents, ACL tears, hamstring rips, that kind of stuff, or even chronic, plantar fascia, IT band, strength is the number one reason people come back stronger, 100%, aside from the rest and the proper protocol with a physician and a physical therapist. And I think before we get started on the specifics of some of the injuries, I think the most important thing as somebody who's a coach or somebody that's guiding the program for you guys is that we need to have a clear answer of what's kind of going on. And I think the most challenging thing for me is when athletes don't know what's going on. So, my hip hurts or my back hurts or my leg hurts. And I'm always going to push back and say, you've got to go to either the doctor and have an MRI or an X-ray or something like that, so you can get some kind of clarity on what we're dealing with. Or you can start with your physical therapist. If you have a good PT, go to the PT, have an assessment. If they think you need to see a doctor, see a doctor. If they can kind of assess what's going on, tight IT band. Okay. Most people are afraid to go to the doctor because they're afraid the doctor is going to say, don't run. That is not usually the case when you go see someone like Denise, or someone from my perspective is not going to say don't run unless it's obviously an acute injury. So you just have to kind of put those fears aside and get a diagnosis, because once you have a diagnosis or an idea of what's going on, then we can come up with an action plan. And all you type A people listening to that, I know that that's what you want. You need to have an action plan. And so an action plan that we can say, okay, it's plantar fascia. Perfect. This is what we're going to do. Here are the symptoms. This is why it happened. And then people like Denise can manage the whys, the movement patterns, the weaknesses, the form issues. And then someone like me can say to you, okay, this is what we're going to do in place of running. We can do elliptical. And so then we have this whole team working for you to put you back together. And it doesn't mean you have to stop training unless obviously it's an acute injury.
Great. All right. Well, we'll start with plantar fasciitis since that's what Jen just brought up. So plantar fasciitis is probably the number 3 injury I hear about starting in about July. And that's when volume starts to pick up for people training for Chicago or Madison. So we haven't quite seen injuries pop up yet for those training for Rockford. for Ironman Rockford, but the timing will be, it's coming up here because we're almost to June. But plantar fasciitis is pain that is in your heel, sometimes on the inside of that heel, or you may feel it in your arch. Once in a while, it may be deep in the middle of the heel, but a lot of times it's off to one side of the heel. And it can sometimes be misdiagnosed. You may have posterior tibialis tendinitis, which is a tendon that comes on the inside of your calf and also attaches into that side. So a lot of times a very well-meaning podiatrist or sports med doc may just kind of push on your heel. The patient jumps up in pain. They describe pain when they first get out of bed in the morning, when they first start taking those steps, or pain as they walk down the stairs in the morning, or achiness when they first stand up after sitting for a long time at work. And so posterior tibialis tendinitis and plantar fasciitis can mimic each other because of where that insertion point is. So that's always why we like to do other tests as physical therapists to see what other tenderness you have when we're pushing around on it, and also what makes it feel better. So it happens because you're loading that fascia wrong. So that could be that if you are landing with your foot too far ahead of your body weight when you're running, or you wore a pair of boots or a pair of high heels that threw off the tension in that fascia. It can become irritated, and the fascia is a soft tissue structure that is not a tendon and it's not a ligament. It doesn't have a blood supply. So it doesn't heal the same way as just a tendon would. So it's sensitive in different ways. It's sensitive to tension. And some people will like roll out their plantar fascia. That usually doesn't do much good because there is no blood supply. So it's not healing the same way. There's a muscle that runs underneath the fascia that's responsible for flexing your big toe. Sometimes it can spasm, and that can also mimic plantar fasciitis. So that's why someone putting their hands on and figuring that out for you is helpful. But it can affect your training because it hurts to step out of bed in the morning. It may be worse on the days you did a long run, or depending on what shoes you're wearing, you might notice that it gets worse with maybe sandals, but not so bad when you're in your running shoes. So it can affect how you're dealing with it in your everyday life. And we look at inflammation usually in the one spot. So plantar fasciitis, like Jen was saying, an acute injury means that the fascia is irritated for a short period. You may hear the term plantar fasciosis, and that's usually when it's been going on for more than 6 weeks. So it's just to distinguish if this is a chronic problem or more of an acute problem. And like some of these other injuries we're going to talk about, plantar fasciitis sometimes can just be a symptom. The fascia may just be irritated, but it might not be the driver of the problem. So somebody could have a calf strain or a knee problem or a hip problem or a low back problem. And that top of the chain is causing the bottom of the chain to have to work in a different way. And so we always do consider symptoms, but that might not always be the cause. So this is one of those things that you may come in to see us PTs and we're looking at your hips and your low back and you're like, but the problem is in my feet. And we're like, we know, but look, you have a leg length difference, or this joint in your low back isn't moving and gliding the way we want it to. And that can cause symptoms down the chain farther. So there's a lot of reasons why it happens, and it ultimately ends up affecting you. So what we recommend for self-care is spending time with a therapist or a good massage therapist and figuring out where in the chain the problem really is that's starting the symptoms. But taping it can sometimes help, giving it some support. A lot of people will run to the podiatrist who will put them in an orthotic. We have a love-hate relationship with orthotics because it's a brace, and we don't always believe that something should be braced all the time. But sometimes acutely and for a short period, you might need a little bit of bracing, but then we're going to really encourage you to strengthen everything around that, work on the stability of it, making sure the timing during your running is correct, making sure you're loading the right way, making sure that your big toe, there's a lot of research out there about the big toe right now. It's going to pop up on all your Instagram feeds now because I just said that out loud. But the role of the big toe is no joke. So learning to use your whole foot properly is a big deal because the fascia then can be offloaded because the rest of the muscles and structures are helping to support it. So Jen, what happens then when someone's having pain anytime they're putting weight through their foot with how they're going to modify their training?
Yeah. So when people come to me and they have plantar fasciitis, which is frequently, I kind of go back. Remember, I'm the non-medical person. I'm just trying to get people back to training or in training or to the races. So I look at it from, okay, what do we need to do? Usually people are walking simple things. They're walking around their house barefoot on hardwood floors. So I'm making sure they're in shoes, and not what's happened is that we've in these overcorrected shoes and all these kind of squishy shoes, and it's not allowing our feet to also get strong. So I also make sure that they're doing some of their life barefoot. That doesn't mean walking around the house, cleaning the house and living your whole life barefoot on hardwood floors, but a little bit more of doing some of your strength work at home barefoot. Doing some of that where you can just, honest to gosh, some of these feet exercises, you guys Google it. I know it sounds kind of weird, but it helps. It helps a ton. It also helps with some of the other stuff we're going to be talking about in a little bit. And I always tell people, if the pain is higher than a 4, then don't train and push through it. I just had an athlete literally this weekend. She's been fighting plantar fasciitis which is now fasciotis or whatever, for months. And now she's a stress fracture. So it will turn, because what's happening is you're going to change the way that your feet land and you're going to overcompensate. And so the root of the cause wasn't addressed. So that's where we have to be really careful. Yeah. So I would change the training. I would try to take the load off the plantar and do stuff like, the boring stuff, right? Like if you're not too close to a race, the elliptical is great. I know it's boring, but the elliptical is great. And obviously if you're a triathlete, we can cross train, and then we can do some aqua running. That gets a little bit more pertinent when we get closer to a race, because that's kind of boring, but you can get super creative with the plantar and it does like a little bit of rest. So once the race is done, if you can rest it a little bit, sometimes that will help heal that up. But this is chronic. This is one of those things that doesn't go away very quickly. And the things we talk about tonight are things that people deal with all the time, unfortunately.
And I think that, look up toe yoga. That's one of those ones
Yes.
that, is a really challenging and frustrating one to do, because you're gonna be like, why can't I move my toe by itself? But there's a lot of things happening 1/4 of your body's bones are in your foot and ankle. So the intricacies of the foot and the structures that support it need strengthening just like anything else. And there's this famous picture out there that it's like your foot is your core. And so you'll see an AI image that is like abs, like a 6-pack on the bottom of your foot, showing how strong and stable that base for us has to be to help support everything above it. So when Jen's talking about all those other things, it's to keep your heart going. It's to not lose that cardiovascular endurance. But you can do the strength training, you can do the aqua jogging, and work on things like your technique. Work on loading through that big toe and learning to take pressure off the fascia. It's really great way to make sure that you're still making gains, even though you may not be getting mileage. And I always recommend seeing a professional when it's not going away, or it's now starting to affect your daily life, where you dread getting out of bed in the morning, or you feel like you have to be in shoes 24 hours a day. It's time to see someone. And there are really good sports medicine docs out there that will help you rule out that there's a fracture or rule out that there's a tear. And that's what we need to know, is if there's nothing wrong. I mean, I think sometimes with MRIs and x-rays, people almost want there to be something wrong to explain why they have the pain. And when there isn't something wrong, they get frustrated, like, why am I going through all this? Now, as a PT, we love that. We don't want there to be a serious injury. And it makes us have to work as a body detective to help you figure out what's driving it still. So, advocate for yourself. If you go see a doc and their first reaction is, well, maybe we should brace it, be like, well, can we rule out that there's nothing seriously wrong? And then take some steps from there, so you feel like you have an action plan to address the cause of it as well as the symptoms. Anything else you want to add on plantar fasciitis, Jen?
No.
Okay. Here's one that's near and dear to Jen's heart.
Yep.
So Achilles tendinitis is another one that can sometimes be misdiagnosed. True Achilles tendinitis is pain in the Achilles tendon. So it's that thick tendon in the back of your lower leg. The tendon comes off of your gastroc or your calf muscle. And underneath your big gastroc or calf muscle is another broader muscle called your soleus. And sometimes that soleus can become irritated. And so again, this is why palpation skills are so important, because if you press off to the side of your Achilles, it might actually, and that's tender, that might actually be the problem, not necessarily right in the meaty part of that Achilles. So understanding why either the muscle or the Achilles, the tendon itself, is mad will help you understand what's driving it. Why it happens, it can be something as simple as, and you will also have some tenderness when you first step out of bed in the morning. But the other reason why it happens is that a lot of athletes will try to push off the ground. And what that does is it sends you up in the air and not forward. So driving that foot off the ground can cause irritation, because that tendon's job isn't to propel. It's not meant to load that way. Its job really is to help control landing. So it's happiest when it's working eccentrically. So that means when it's slowing down movement against gravity. So that's why you'll see some of the exercises for Achilles tendinitis are heel raises up, but slowly lowering down. So if your feet are hanging off the edge of a step, the instructions you'll see online will tell you to go up on your tippy toes, but then slowly lower your heels back down off the edge of that step. And so that's how Achilles is designed to work, is eccentrically or slowly lowering you down. And so that type of eccentric work is a great way to train, especially if you're working on prevention. So single leg squats, working on squatting really, really, really slowly and then coming back up. It's a nice way to load that Achilles. Your quad also likes to work that way. So those kind of exercises are wonderful prevention tools. Again, Achilles tendinitis can also come from something higher up the chain. I'm going to sound like a broken record that everything is connected. That is true, that like the hip bone's connected to the knee bone. So all of this can travel down. Sometimes you can have a low back problem at like your level 3 or level 4 in your low back. And it can cause some ridiculous symptoms down into that Achilles. So understanding that, how your hip is extending back, and if your trunk is leaning too far forward when you're running, can sometimes cause some irritation. And self-care does really focus on, and Jen will say this too, is rest is important with this one. This can be a very chronic thing. And so resting, meaning maybe not running, but Jen can talk about some other stuff to do. But stretching is great, but this one is really focused on strength training, as well as proper diagnosis to make sure that the right structure is being treated, but also that all the mechanics of the ankle and everything above it are moving the way they're designed.
Yeah. And, talking a little bit about Achilles tendinitis from somebody who's kind of chronically had it on and off as a master's athlete, Achilles tendinitis, to bring it home a little bit, one of the things that I found that was causing problems with me was I was just super tight and not flexible in my flexion and dorsiflexion of my ankle, which is surprising because I'm a swimmer by trade, but I just, just did not have great flexion and dorsiflexion. And I had super tight peroneal tendons and anterior tibs. And those are the Denise can explain it better than I can. I'll put it in layman's terms. Those are the tendons that surround the inside and the medial and the lateral side of your lower leg. So those were super tight, but I had no idea. I just couldn't get the chronic Achilles to go away. And did all the strength, did all that. And it wasn't until I really had some manual manipulation in there, where like to the point where I was like jumping off the table from either Denise over the years, or my athletic trainer, Jim, at Northwestern, who just kind of got in there, dug in there, used all those scraping tools and all that, and just try to loosen that up. I found that I wasn't able to put my foot flat on the ground, not sitting in a position like this, but like, maybe sitting back. I would kind of always externally rotate. So it was just weird. So just those little nuances. And once I was able to kind of get that sorted and get those muscles to release and make those stronger, really helped my Achilles tendonitis. I absolutely had an MRI done on my Achilles tendonitis after I went back and forth over the years with problems, just to make sure I had nothing torn. Back to what I said earlier, it's really important that I knew mentally that nothing was torn off, off with that Achilles tendon, so that it wasn't something that I'm trying to jam a square into a round hole, because I can't do anything if it's ripped. I need to know if it's ripped, because then you have to have a different course of action. The MRI came back as just a normal Achilles tendon with a normal frame for somebody my age. So at least mentally, then I was like, oh, I'm good. Then I'm going to keep loading it, and I'm going to keep. But I will say, did take 8 weeks off at one point. I can't remember when it was, but 8 weeks totally off running to heal that chronic Achilles tendonitis, and it did work. But I needed to take that rest. So the Achilles likes to be low, likes, like what Denise said, doing with that. But you also have to get to the point where if you're in pain just walking and it's affecting your life, and I was limping, then that exceeds this pain higher than a 4 threshold. And then you just have to do a really good job with chronic load management. You have to be able to figure out if we're loading this too much, and I was just loading it too much. And so that's when you get into back to the, elliptical, back to the aqua jogging, back to, more cycling, more swimming and stuff like that, just to kind of release that load a little bit. And it helps.
And I think in times like this, it's also good because you can work on other parts of your swimming technique. Let's say you can't push off the wall because that hurts, but maybe you have a pull buoy and you're using, you're really working on your breathing or your trunk rotation or your hip rotation in the water. Sometimes that also helps gets a mobility that you weren't focusing on before, and improving the mobility of your pelvis, your lumbar spine can actually help an Achilles issue. I know it seems weird, but again, if something higher up the chain isn't moving quite right, the rest of the chain has to address that tension. And so working on hip mobility, lumbar mobility, thoracic mobility, even shoulder mobility can help problems down in the ankle. So I know it's boring to do things like yoga, but for those of you that have Peloton, there are some yoga Pilates classes that are combined. I did one today, it kicked my ass. So there are some really hard workouts out there that put in mobility that doesn't make it, we are used as runners, we're used to like sweating all the time and we think that's the good workout. But sometimes being able to just hold a certain position, which is what the Achilles likes to do, is a great way to train to work on mobility and stability at the same time. So finding yoga or Pilates classes, it's just a different way to train. And so being okay with that you're not sweating isn't always the worst thing in the world.
Well, that's for sure. And I think the other thing too is communicate. I think people wait too long to get help with an injury. They keep pushing, or they'll modify it, or they start running differently or doing stuff. And it's just better to address it. It doesn't mean that whomever your PT is, or if you're working with somebody, that person's going to totally strip you of all your ability to run. But it just means that we tweak things. So keep the runs flat versus hill repeats and intervals on the track, which the Achilles does not like when it's inflamed and angry. So anyway.
Yeah, or even like trying running backwards. Sometimes you'll see your symptoms go away when you run backwards. And what that tells us is that your stride is too long. And when you load the tendon the right way, that Achilles doesn't care. It's happy because you're now loading it properly. And so sometimes
these are triathletes, they need to wear helmets when they run backwards. Do not run backwards on a treadmill.
Well, yeah.
Like, no.
That's the other thing. The treadmill is, I also have a love-hate relationship with treadmills. I know we have to do it because we live in Illinois, but if right now as things are getting nicer out, being in the grass in your bare feet or being in sand in your bare feet, there's a strengthening component to the control that needs to happen at those smaller intrinsic muscles. But that awareness of movement, you might see symptoms change when you take away these squishy hokas that everyone likes to run in. You might see, or if you're doing squats, wearing hokas while you're squatting is like squatting with your foot in a bag full of gummy bears. So trying to come out of that and doing squatting, you might see that you tend to roll one way that you can't feel when you're in these like cloud-based shoes. But when you're barefoot and your feet are, you might see how you're compensating, where there might be some lack of mobility, like Jen said, in your ankle. And that's where you might be like, oh, well, now I understand why my Achilles is working so hard in the back. It's because the front of my foot isn't working.
Mm-hmm. Yeah. And the last thing I'll say about Achilles tendonitis is some of it is just the way that you're built too. Sometimes we're trying to fix things that we are anatomically just not able to fix. And that's okay. So you need to know what it is, address it, and then work with a physical therapist to kind of say, okay, this is what, this is what's going on. I was born this way. What can we do to fix this so I don't have problems down the road? I see that actually a lot with athletes. And so there's always a way to fix things.
Yep. Shin splints, we're not going to spend a super long time on because most of the people on this call are fairly experienced or have been doing some more volume of running. But you may have a young runner in your life, a high schooler, that does have shin splints. So we wanted to mention it. And this is usually what leads the most to stress fractures. And it's not that shin splints themselves cause the stress fracture, but the muscle that gets irritated is your anterior tibialis, so the muscle right in the front of your shin. And when it's mad, it will pull on the bone, and that's what ends up causing the stress fracture, is that tension of the bone through that muscle pulling on it. So we're going to just cover this one briefly. This is that pain right in the front of your shins. Jen, I think, had mentioned to me that she sees this mostly in some inexperienced runners who just haven't had the volume yet. Is that what you said?
Yep. And which kind of leads into a little bit sometimes the younger runners or less experienced runners where they're not used to, they're starting too fast, going too fast to run. They're in really crappy shoes. So you see a lot when I coached at the high school, collegiate level, and the middle school, these kids had shin splints all the time. So of course it has to do with form and strength. But the problem with shin splints is that some of the doctors want to put you in boots, and that's not necessarily, I'm not a doctor. I just play one on Training Peaks, but I wouldn't, it's usually a strengthening issue. The problem with shin splints, and Denise can talk better to this, is it turn into stress fractures if you're not careful. So that's what you have to be super careful about with shin splints. But I don't see this as often as what we're going to be talking about, next, like hamstring stuff. And
the age group that we see this most in is like 15-year-old females. And if you think about what's happening to a lot of girls at 15, they're going through puberty, they're growing. So some of them are like these baby giraffes and they're unstable through their pelvis. So that instability will cause a rotational movement when they're running. So that combined with weakness and poor form causes the ankle to like almost collapse, or they might land on the outside of their ankle. And that rotational movement, the shin muscles or the lower leg muscles are like, wait a minute, like now we're having to control this side to side movement. We want to only control forward and backwards. And so the muscle fatigues and starts basically getting a form of tendinitis because it's having to control movement it's not designed to do. And so it starts pulling on the bone and becoming irritated. So the treatment for this really is technique, heavy strengthening. And a lot of times you just got to finish the growth spurt if you're a young athlete. But so we can talk more about that if somebody has questions, but
yeah, the only thing I'd add there, Denise, that I see sometimes, if you're listening, if you're a newer runner, is sometimes the camber that's on the road. Sometimes I'll have athletes that get a lot of the shin problems because they're trying to manipulate the roads and stuff like that. Not like a road that's undulating, but more of a road where the camber's off. So I see that a lot. So just switch up your running routes to manage that. But that's a sign that there's weakness there too, of course.
Anybody that's ever run a Disney race, half the time you're on these like exit ramps and you're like curving the same way every time. You'll hear people as I'm running, I've heard them be like, God, my shins are starting to hurt. And it's simply because they're just on that embankment. And they haven't trained like that and they haven't worked on that muscle control yet. So super common when you're on, or especially if you run the same way on a track all the time, you may notice it. So. Okay, knee pain. This is a beast. So we're really only going to talk about outside knee pain, which usually is an IT band problem. There are things like runner's knee, which is pain on the front of the knee, usually the lower part of the knee pain or the lower part of the knee. So we're going to mostly talk about the outside knee pain. So the IT band inserts, it starts at the top of your hip and it inserts down by the outside lower portion of your knee. It is also very similar to the plantar fascia. That is, it's termed an aponeurosis. So again, that is not a tendon and it's not a ligament. So this may come as a relief to all of you, but you do not need to roll it out. It does no good to roll it out because it just hurts like hell. But there's no blood supply. So there's no point to rolling out right directly on the IT band. What we recommend is usually there's a problem with rotation again. So usually a technique flaw, some weakness in the pelvis that's causing this drop on one side. And I know a couple of my runners that are on this call right now, you remember when we watched the video, when I film you from the back, you see that when you're on that single leg stance on that one side, you see that opposite side drop. And so that constant side to side balance, the IT band's like, I can only handle this for so long because it's trying to pull you back into position and it's not designed to load that way. So it gets really, really mad. And so people will like try to roll out their IT band, and IT band symptoms can come on when you first start running, but then once you warm up, it goes away. And then later on, it'll be sore, or it might progressively worsen as your run is going on. And there's a slight difference in why that happens. And us technique specialists can tell you why that happens, but generally it comes from weakness. It's glute weakness, sometimes a lack of hip mobility, so lack of range of motion, but glutes need love. Like glutes and hamstrings really need love in this case. So addressing some of that strengthening. And if you want to prevent IT band issues, do single leg strengthening exercises. So I know clamshells are like the favorite exercise that people lay on their side and do the clamshell. Don't do it laying on your side. We're never on our side as runners. If we are, there's something wrong. So do it standing on one leg with some resistance. Work on standing on one leg, bringing that leg out to the side and back in. Be in functional positions. So if like bridges, do a single leg bridge. So you have one leg up and one leg down. So your pelvis learns how to control itself when there's movement and you're on one leg. So that is some of the best stuff you can do for prevention. But as far as self-care, when you do have an IT band issue coming up, start working on that glute strength. Start working on your hip extension, mobility. Start working on your rotational mobility. So that there's that like 90-90 position that you can sit in, or I call it the mermaid, where you have both legs are kind of at like a 90 degree and you go to one side, then the other, and you'll just feel the limitation when you tilt to one side. So those 90-90 or the mermaid position is really a great way to work on that range of motion of your hip. But also if you want to do some soft tissue work, again, don't roll out on the IT band. It does no good. Get in the quad, get in the hamstring. So the stuff that surrounds that IT band, that travels underneath the IT band, start trying to take tension out of that, because that will help give a little more glide and slide to the IT band. Because it functions like it's a thick fascial structure. And, Jen will probably talk about, watching your volume of running when you have this irritation.
Yeah, this one is not fun, because it's kind of like plantar fascia, where you feel like it's just never really goes away. Sometimes with the Achilles, it comes and goes. But I find with the IT band, it's one of those that kind of just that lingers around. So the best advice is, with the training on this, is that you can keep training with IT band, but you just have to do the body care, the strength and the mobility on top of it. It's a little different with, like something like the Achilles, which sometimes just needs to rest from the running. You can continue as long as it doesn't get worse. And the thing is, with all these injuries, the real red flag for me is, from a coach standpoint, is if this stuff keeps you up at night. Or if you wake up in pain at nighttime. I always say to athletes, were you up at night with this pain? And they're like, oh no. And I'm like, okay, all right, we're good. Like we need to modify stuff. We need to bring down intensity, of course, bring down the volume, decrease frequency. But if it's not keeping you up at night, it's usually a good sign that you're not getting worse. I think if you wake up with pain in the middle of the night, or it's making you a little nauseous, then that's the red flag where you need to kind of halt the running. It's usually the running. Sometimes the cycling will bother the IT band. So it just depends, but back to the elliptical, back to your bike or the Peloton or something like that, and just keep the load lighter. So this is a nice one. This one does heal from I find that most athletes can kind of manage this with some massive yoga and like stretching and stuff like that. Back to the boring stuff, and single leg work, of course, which most people don't do enough of. Single leg strength work, RDLs and stuff like that.
All of our favorite stuff. So, and this one doesn't have it's not like the Achilles or the plantar fascia where it could be another structure that's close to it. When you have IT band syndrome, you have IT band syndrome, and it's very rarely anything else. So once in a while, if you have an ankle sprain on the same side, you may notice, and you feel like it heals, but a couple months later you develop the IT band issue. Sometimes that can be a bone that gets stuck in your lower leg, your fibula. So the outside leg bone can sometimes get subluxed and stuck during an ankle sprain that you don't really know until you start running. So sometimes if you're like, oh, I did have an ankle sprain a couple months ago, that's important to let your therapist know, because then they can address the biomechanics at the ankle to make sure all the joints are gliding and sliding the way they should.
Before we move on, there is one question.
I saw that one about the shoe wear. I thought we could tackle shoe wear
at the end
there, if that's okay.
Just don't forget about it.
Okay.
I
know you do.
Hamstring.
I'm going to come back to this hamstring one because Jen and I feel like this is probably the most common one. So we're going to come back to this one and move into this. Again, this hip pain can be a lot of things. Hip pain, we're focusing mostly on like deep hip pain because there's a couple red flags with this. So hip pain can be a variety of things. It could be pain that's like deep in your butt muscle, not necessarily your hamstring, but more deep in your butt. This can be pain that radiates into your groin. This can be pain that might even feel like it's up in your private area. This could be pain that might be in your low back, but it kind of feels like it's your hip. So this one is really important that number one, this one would be, if there's certain things you say to me, like if you say to me, it feels like it's stuck or it clicks or it clunks, or if the pain is radiating into your groin, those are two red flags. And I'm like, we're going to go get this. I want you to have this x-rayed or MRI'd because we want to rule out that there's any impingement or any damage to the labrum, which is what holds the ball in the socket. So this one I don't mess around with. I don't try some stuff first. This one is one where I'm like, let's not mess around with this. And deep hip pain can happen for so many reasons. You could have, like I said, some low back dysfunction that's radiating into your butt. You could have some entrapment of your piriformis muscle as well as the nerve. You could have a labral tear like we talked about, or some kind of impingement. It could be something like pelvic floor dysfunction. So if you also are getting some incontinence where you are either peeing your pants while you're running or laughing or coughing or sneezing, like there's most likely that instability, that those pelvic floor muscles aren't supporting your hip and pelvis the way they should be. So hip pain can be a gamut of reasons, but this is when I usually say, the hip is way too important. And there's 22 muscles that cross your hip. So the anatomy there is so intricate that all the comings and goings that are in there, along with that pelvic floor, whether you're a male or a female, it's an important thing. And we do see a lot of women coming back after, that would be another talk we could maybe do, Jen, is returning to running after a baby.
Yeah.
But we see women wanting to come back really quickly and going to running, but maybe they're still breastfeeding and there's some instability. So, making sure that all those systems are cared for and ruled out, most importantly.
Yeah, the hip pain, I agree. Usually it's so complicated. And what I see a lot of are the torn labrums, and they just need to be diagnosed. So whenever it's this kind of hip pain, it could be piriformis, it could be TFL, it could be, and so initially it's the massage, it's the body care, it's the yoga to make sure the hips are loose, but everybody that's listening to this, including Denise and I, have tight hips, just from sitting, driving, doing, all that other stuff. So the modifications with this I kind of require some kind of MRI or some kind of understanding of what's going on and then modifying it instead of the other ones. Oh, we can keep playing with it, keep trying, see if it gets better. But I agree with Denise on this one.
So we're going to get to like the meat and potatoes here of like what Jen and I probably see as the highest incident of injuries is this high hamstring strains or tears, like in the muscle belly, the lower part, usually happen from sprinting. And it's usually because somebody's trying to do something they're not supposed to do. This is different.
I've got so many stories for this one. I've strained it, I've pulled it, I've ripped it, I've done everything.
Ripped it right off the bone.
Yeah, I've done it all. But this is by far the number one issue is high hamstring tendinopathy. Can I share before we talk about it? Can I share my all-time favorite podcast?
Yeah.
It is, and I can put this in the notes or Megan can help me put this in the notes. It's called Overcoming Proximal Hamstring Tendinopathy. Can't really say that very well. Podcast. It's hosted by Brody Sharpie.
Send it to me, Jen.
Okay.
Can you just text it to me and I'll put it in the chat?
Okay, I'm going to text it to you. So it is, I've listened to every single one of them. I have done a doctorate, kidding, and hamstring stuff, because by far this is the number one issue with people. I know there's people on this call that have I call it HHT, high hamstring tendinopathy. So I'll let Denise talk about, from the medical standpoint, the symptoms and why it happens, but we can talk a little bit about this one because this is a pesky one.
And just to ease all fears, it is very hard to tear this. But for trauma, which Jen can attest to, it is almost impossible to tear this off the bone. So if you just have tendinopathy, it's not the same risk as like a plantar fascia where there's some fraying that can happen. So you can work through this. It's just a pain literally in the ass. So the symptoms are, it's almost like on your sit bones, there just feels like there's a pinching or a burning or a pain. It happens mostly when people are sitting and driving. That's when they'll notice it. They'll sometimes try cushions and that'll alleviate it, but it's that pressure on it that irritates it. Sometimes they can run through it. Running doesn't always irritate it while they're doing it, but later on they pay the price. They have trouble sleeping at night. They can't quite get comfortable. It always feels like they want to be stretching it, and they'll be like, I stretch it and I stretch it and it never gets better. That is the main symptoms that we hear when we know it's this high hamstring tendinopathy. And Jen, I don't know if you want to give any like personal or.
So starting with the hamstring, there's like, I think it's important to understand there's 3 levels. And Denise, please correct me because I'm going to talk in coaching words, not medical words.
You're doing fine.
There's 3 levels of a tear for a hamstring. And I always say to athletes, okay, let's step back. Level 1 is where, when you're outside and you're like, I think I just hurt my hamstring, or that hurt. Well, that's a level 1. You just kind of made it, crabby. Then there's a level 2, which is in the belly of the hamstring. You're sprinting, or in personal experience, 5 or 6 years ago, I lined up at a 10K, probably didn't warm up well enough, thinking I was 15 or 20 or 30, and started sprinting to the thing. And all of a sudden I'm like, and I ripped the medial hamstring, which put you out for me, someone like me, 6 weeks. And, you can keep moving, which we'll talk about later on how to manage that. So that's a grade 2. And then the grade 3 is the avulsion, where you rip the hamstrings off the ischiotubosity bone. But the grade 2 does happen a lot with people. And I know for a fact it's caused by just things being over tight and just being super kind of weak and doing like what Denise said, sprinting when you're not warmed up, or doing things like playing pickleball when you're not warmed up and going for a ball. And, obviously you can do other things with it. So there's 3 levels of the hamstring with those tears. Denise, would you add anything to that?
Yeah, I mean, like water skiing is another thing we see. A lot of people will try this water skiing and that'll, they don't pull up quite the right way. And that's when they'll really feel something go. So this is, the hamstring is a fascinating muscle. Like, it's one of my favorite muscles in the whole body, but it also is, I think, probably the number 1 undertrained muscle in the body for runners and triathletes. So it loves volume. That's what it's meant to do. It's meant to be, it's the true workhorse of running. Its job is to pull your foot up off the ground and pull that leg through during the swing phase of gait. So that is what it wants to do, but it likes rhythm. So it likes consistency. So some runners have a tendency to not get their leg through, pull it off the ground fast enough. And then at the very last second, the body, this is all happening inside your brain, is like, oh my God, hurry, get your foot up off into the right position for because you have to land almost. So it might be really slow, dragging behind you, and then all of a sudden it speeds up at the very end, and then that slow pull, and then a quick activation at the end. And that inconsistency, the hamstring hates. What it does love is rhythm. So when we're rehabbing somebody with this tendinopathy, we use metronomes. So this slow beat, I'll have them do standing hamstring curls or bridges, but they're following or RDLs, they're following a metronome. It could be slow or fast, but they have to keep up with that rhythm because the hamstring loves that loading consistently. So if you're doing like bridges or hamstring curls at the gym, think about a song that has a beat and keep using that beat over and over and over again. And working on some of those muscles that are in your butt. Massaging the actual tendon itself can actually make it more irritated. So massaging everything around it. So the muscle belly, the glutes, the piriformis, kind of get all the structures around it to calm down. That's a great way to do some self-care. But again, bringing in the hip mobility, pelvic floor strengthening, your breathing. Your breathing is a big part of hamstring. So if you tend to hold your breath, most of us breathe incorrectly. And I am not a breathing expert, so I don't want to talk about that. But working with somebody on breathing is really important. And I know that seems weird that your diaphragm can affect your hamstring, but it can, and it's all through these fascial attachments that happen through the pelvis. So consistency, rhythm, and strengthening are the biggest way that you can prevent a high hamstring tendinopathy.
Yeah. And the other thing that's just to keep it super simple is the hamstring loves load. And the hamstring doesn't like to be stretched. So when we say load, adding on to Denise's rhythm comment, a lot of strength stuff. The only way that I could rehab that high hamstring tendinopathy for myself, and so I had that, and of course I don't know what the term is, but ripped or pulled that, the belly of the hamstring in addition, was once that was healed, then back to all the single leg stuff. I mean, I literally spent 5 or 6 years spending out 2 hours a week in the gym doing things like isolated hamstring curls, bridges, single leg, Nordics. So if you don't know what a Nordic is, that's kind of when you're on your knees, someone holds your ankles, or your ankles are locked, and you go forward as far as you can. It takes forever, go forward. Sometimes you can come back, but just those kind of eccentric and concentric movement of the hamstring. And just things like squats, Bulgarian squats, because they're single leg, do them loaded. So, and working on that, honestly, that is from experience, not only personally, but with all the athletes that I work with that have HHT, that's the number one 100% fix for the high hamstring tendinopathy. And it is. The other thing that something to pay attention to that I look at with athletes. So if you are running and someone's not looking at your workouts, that's fine. Pay attention to your cadence. Because what I find sometimes is if cadence is under 165, that's my personal number for my athletes, but it's under 165, that's how many times your feet hit the ground in a minute. If it's under that, then we're spending too much time on our feet, and we're not quick with the, can I say pull, Denise? Is that an okay word?
Yep, that's right.
Okay, good. Pull with the foot up, and it's too slow. So we're creating all this load on the body, and the body hates it. So we're having problems, either hamstring, the IT band, the hips. And so working on your cadence, strength, and form with this high hamstring tendinopathy is key. You can train through this, but you just need to be super careful with the speed workout. Hills, sometimes the hills bother it when you're coming back from something like this, but you can still run with this. Back to if the pain is over 4 on a scale from 1 to 10, then I wouldn't run with it, but it eventually heals. But it is one of those chronic nagging ones that sometimes just cannot figure out how to fix.
Yeah, and I think if you work with your cadence doesn't necessarily mean that you're pulling your foot super high. It's just how fast you're pulling your foot through. So that consistency. So cadence training is an awesome way to work on loading the hamstring the way the hamstring loves. So using that metronome again, using a song like Rock Lobster by the B-52s. It's a great song that you can hear that beat. So in the interest of time, I want to address the question about shoes. So my recommendation on shoes is variety. So I know whoever posted that says they don't have Hokas, and I don't have anything against Hokas. I just hate that there's so much cushioning that people think that's what they need. So I like shoes I like when people train barefoot, not necessarily running, but training. So strength workout or technique drills. I like if people do want something with cushioning that they also wear some kind of track flat. So that you just have this variety. So no matter what condition it is, you may want a cushioned shoe when you're doing your race, but all your other training shoes are varied. So there's 2 things I'm primarily concerned about. One is the drop, and the other is cushioning. They're not the same thing. So a drop indicates that some of the Sauconys are a 12 millimeter drop. So that means there's 12 millimeters difference between the back of the shoe and the front of the shoe. Versus a zero drop like an Ultra or Zero XERO is another brand, or Vibrams. They are zero drops, meaning there's no difference in height between the front and the back. If you can have a variety of shoes, and I don't mean 12 pairs of shoes. I know some people like Megan love different shoes. So, and they have different shoes for every outfit. So, if you can have options that maybe you're like, okay, you know what, today I'm going to go on a trail run. So I wouldn't mind wearing something that's a lower drop so I can really work on my footwork. Versus I got to do a 12-mile run today. I want to wear cushion shoes. Great. And like Jen said, there's times you're barefoot in your home or you're lifting in your house. But then there's sometimes maybe you want to wear something with just a little bit of cushioning. As long as you are training your foot in different aspects, you just got to find the shoes you love that have the amount of cushioning you like, that look good. If you don't like the color, you're never going to wear them. And that you can vary it so you can work on the strength and stability of your foot in varied situations.
Can I add on to that? Back
Yeah.
to the Achilles tendinitis. What I found successful with athletes that have Achilles tendinitis is having a bigger drop. So usually those athletes, not everybody, but most of those athletes do really well in the 10 to 12 millimeter drop, because there's just less drop for that Achilles to drop every single time. Sometimes with plantar, and again, this is just from a coaching standpoint, not from a medical standpoint. Sometimes plantar problems, just put them in a bigger drop. I personally am in a 10 to 12 millimeter drop because I've always had Achilles issues and obviously coming off of hamstring surgery, but that drop is really important. So if you're having any kind of problems, that's your foot, like Denise said, to tie it all together, is the basis of your entire body, those feet. So if you can protect those feet and get them into a proper drop, whether it's a 6 millimeter, 8 millimeter, 10, or 12, then that really kind of helps take the load and distribute the load properly up the kinetic chain. And that's super important.
Yeah. So I hope that answers your question, Anonymous, about shoes. And again, Jen and I could probably have an entire conversation about shoes, because it's a beast itself. So if you guys come up with other questions later on, please send them to us, and Jen and I will get them answered. And I do feel like, Jen, we could have conversations on more stuff with this. So
do we answer? Have any questions that we can answer tonight for you guys while we have another minute? Anything specifically on HHT or? Yeah, Rick. Hold on, Megan, can you help me with Rick's question?
He hasn't actually asked one. He just raised his hand.
Oh, okay, Rick, do you have a question? No.
You want to type
Well,
in
I
the box?
think I think Christine and I realized that if people are on their phone, there may not be actually a way for them to write or type in a question.
Oh, okay.
So I'm not
Well,
sure.
here, let me see if I can let him.
Well, I
type.
will say that Rick is dealing with HHT.
Oh, there you are,
Hold
Rick.
on, his volume is off. Hold on.
Hey, what's up?
There he is.
There we go.
There he is.
Yeah, HHT, pain in my ass, PRP, all the fun stuff. Denise, out of curiosity, do you guys do a gait analysis to determine if your gait is part of the issue?
Yes, so we don't film on a treadmill though, so that's where we're a little bit different. We film from 4 angles while you're actually running on the ground, so we can see what is happening when you're actually running. So we use video analysis to analyze that, but from 4 different angles while you're running, like on the road. We're having you run as if you, or sometimes we'll have people bring in videos of them running in a race or at the end of their runs, so we can see what happens when they're fatigued.
Okay, cool.
We do
Yeah, I
it
would love to
virtually
get,
as well as in person.
okay, cool. Yeah, I would love to get rid of this because it's been an issue and, like everybody else, not fun.
Well, thanks for the question. And, if there's specific things, let me know and you and I can talk offline about that. So, I'm again, Jen, I'm really, really grateful that we got to do this with you. And I think that there is so much else out there we could talk about. So if anybody has any other ideas, we would love to hear what it is, about some other webinars that you want to talk about. So we just feel like the more our athletes are empowered to know how to move the right way, the better your performance will be, the lower your injury risk will be. So that's our whole goal with doing these webinars.
Yep.
So,
Perfect. Thanks,
all right.
everybody.
Thanks, everybody. And we'll be sending out, right, Megan?
Yes.
Sending
So give us like a day or so, and this link will be sent out via YouTube link. So everyone will have access to it. And if we do need to schedule a part 2, or if there's more questions, you can always send them to me, and I will send them to the gurus and get you answers back as quickly as possible.
All right.
Yep.
Well, thanks, everybody. And we'll be in touch soon.
Thanks, everybody. Bye-bye.
All right. Bye, Meg. Thanks. Thanks, Jen.
Thank you.